This slide's presentation will provide basic information about the pathophysiology of stroke. Most of the information is taken from O'Sullivan in chapter 15. Just some basic statistics. There are about 795,000 strokes per year in the United States, and stroke is the number 5 cause of death in the United States. It's also the leading cause of disability among adults. It costs approximately $74 billion a year in the United States. And if you want to look at the figure on the right-hand side of the slide, you can see on the y-axis you have percent of population, and that's those individuals who've experienced a stroke. And on the x-axis you have the individual's age. And as you can see, with each 20 years of age, there's more than a doubling of the amount of individuals, both men and women, who are diagnosed with a stroke. So this is a large patient population in your future. You should also know that if a patient has experienced one stroke, then 5 to 20% of those individuals will experience another stroke within 1 year. And additionally, within 5 years post-stroke, the recurrence risk is approximately 10 to 40%. And this is what you can see on the figure on the right-hand side of the slide. It's just a basic estimate of the amount of individuals that will have a stroke since the time of their first stroke. And you can see that the dotted line represents 95% confidence intervals. Just a little more on statistics. You should know that African Americans have a greater risk for stroke than Hispanic Americans, and this risk for stroke is higher than Caucasians. Looking at the map of the United States that I have on the bottom portion of the slide, you can see that stroke is also associated with socioeconomic status and or geographic region of the United States. The darker the area shown on this figure, the higher the rate of stroke. You can see there's a large patient population that is diagnosed with a stroke in the southeastern United States. Major risk factors for stroke are shown on this slide. Essentially hypertension, high cholesterol levels, diabetes, type 1 or type 2, heart rhythm disorders, especially atrial fibrillation. Okay, having AFib puts a person at a higher increased risk for stroke. Any kind of heart disease, end-stage renal or chronic kidney disease, as well as age, as I've demonstrated before in previous slides, and race. You should also be aware of the fact that there are a few modifiable risk factors for stroke, and these include smoking, obesity, as well as physical activity. Moving on to kinds of stroke. 3 different kinds of stroke that you need to be aware of, and we talked a little bit about each of these in neuroscience. The first is the thrombotic stroke, or also known as ischemic stroke. Okay, in ischemic stroke, if you look at the picture on the left-hand side, it's pictured right there, and you can see the thrombus is something that forms in the blood vessel and blocks the flow of blood to the brain. With this blockage of blood flow, you get an area of the brain deprived of blood, and this is depending on the area, you'll see different patient signs and symptoms. Okay, this is different than in the middle of the picture. You can see the embolic stroke. An embolic stroke is where a piece of a blood clot comes off of an artery and lands in an area or an artery in the brain, and this embolism blocks the flow of blood and oxygen to that brain area. And then finally, as we talked about in neuroscience, you see on the far right-hand side of the slide the cerebral hemorrhage. And this is due to an actual break in a blood vessel can be an aneurysm in the brain, and we talked about the most common site of hemorrhage in in the brain is going to be a berry aneurysm, which forms off the anterior communicating artery in the brain. And remember, with a cerebral hemorrhage, these blood vessels are residing in the subarachnoid space, so you're going to get an increase in bleeding and pressure in the brain. Okay, a little bit more information about each of these. For the thrombotic or ischemic CVA, is caused by atherosclerotic heart disease as well as hypertension. Okay, if you look at the figure on the right-hand side of the slide, you see the plaque that's built up there in the artery in the brain. And if there's an increase in blood pressure, this is going to promote a decrease in the amount of blood that can pass through that area because of artery constriction. And oftentimes an ischemic or thrombotic CVA is known as a stroke in progress because of this. So as the person may start experiencing symptoms to the lack of blood flow to the brain, but those symptoms will get worse as the artery constricts. Okay, so they might see something small at first that evolves over time due to arterial constriction. Okay, another kind of thrombotic or ischemic CVA is known as a TIA. Okay, and this is known as a transient ischemic attack. And this is kind of like a mini stroke. Okay, it's similar to the stroke in progress, but the symptoms of the stroke are only there for less than 24 hours. Okay, a patient might present with something and that just goes away over time. It's indicative of thrombolytic disease. It could be due to a vasospasm in the artery. And anyone who's had a transient ischemic attack is at very high risk for having a full-blown thrombotic CVA. As far as medical management of the CVA or the thrombotic CVA and the TIA, the first is going to be prevention, and that's where we come in. We want to address modifiable risk factors with our patients. We want to make sure that they're physically active and not smoking and controlling their weight. Okay. If the person has had a CVA or a TIA, the medical management part, the goal is to improve the circulation ASAP. And there's one particular drug called TPA, tissue plasminogen activator. And you should know that with early treatment with TPA, there's a much improved prognosis. Patients who receive TPA in an appropriate amount of time can recover with little to no disability within 3 months. So this is a big deal. Okay, get the TPA. The problem with TPA administration is the person has to get to the ER within 3 to 4.5 hours after their symptoms start. And most people don't recognize that right away. So that's going to be a huge part of patient information that you can help provide. If somebody's had a stroke already, or if somebody's had just a TIA, you need to tell them if they see any of the symptoms, and the symptoms of a stroke are shown on the right-hand side of the slide, and they can be remembered with the acronym FAST. Okay, if they see facial drooping or any kind of arm weakness, speech difficulty, then time is running out. It's time to call 911 and get to the ER as quickly as possible. Other things that can be indicative of a possible stroke happening are going to be sudden numbness in your arm and your leg, sudden confusion, any kind of dizziness, and a major headache, which is going to be indicative of a hemorrhagic stroke. Okay, really, really important. Any of these symptoms, patient gets to the hospital right away. If they receive TPA, their prognosis is much better than if they didn't. Okay, in addition to TPA, they'll use, TPA is actually a clot buster, so it actually goes in and just breaks up the clot that's in the brain. They can also use anticoagulants to help prevent blood clotting, as well as antiplatelets. There's also a kind of surgery that can help, and this surgery can be used as preventative as well. If they find that either the carotid or subclavian arteries are blocked with a large amount of plaque, then they can do something called a thromboendarterectomy, and they basically go in there and just clean out the plaque. Okay, moving on to embolic CVA. Embolic CVA is a sign of heart disease, and it's where an embolism actually breaks loose and travels through the blood supply and becomes clogged in the branches of the MCA. Okay, an embolic CVA typically has a poorer outcome if it becomes lodged in branches of the CVA. The embolism can originate from the heart. Internal carotid artery, as we know, is the precursor for supplying blood to the anterior circulatory system of the brain. It can also come from the carotid sinus. Medical management is going to be TPA, tissue plasminogen activator again, long-term anticoagulant therapy, and there's also something that has been used very successfully. It's called the Mercy procedure. And go ahead and pause and click the active link on the slides presentation. The video itself is just an animated video. There's no audio associated with it, but it gives you a pretty good feel for how this procedure is done, and you can understand how it works. Okay, moving on to hemorrhagic CVA. Hemorrhagic CVA, we've talked about this before, can be caused by hypertension, a ruptured aneurysm. The most common is a berry aneurysm. Berry aneurysms are formed on the anterior communicating arteries. Can also be caused by arterial venous malformation, or AVM. Okay, AVM is nothing more than the areas where the arteries and veins meet. They're not well formed, and it's a tangle of circulatory fibers. Okay, when it gets tangled, then this is more prone to rupture, and you should know that AVM is more common for arterial rupture in individuals aged 10 to 35. Okay, essentially with a hemorrhagic CVA, the bleeding is going to displace the midline structures, and it has a much higher incidence of death than the ischemic or embolic CVAs, with about 30% of the individuals who are diagnosed with a hemorrhagic CVA will die within about 1 month. And that's because the pooling of blood causes increased pressure and a displacement of the midline structures. However, even though it's more deadly than the ischemic stroke, the individuals that survive have a much better prognosis because the brain actively absorbs that blood, and once that blood is actively absorbed, this can take anywhere from 6 to 8 months. The person is much better off as long as they didn't have a lot of midline displacement of brain structures. Okay, medical management for hemorrhagic CVA is going to be hypertension prevention and management. Okay, if there is a ruptured aneurysm, that person may require surgery. And if there's a surgery due to a ruptured aneurysm, you need to be aware that there might be head-of-bed restrictions. So, for example, head-of-bed might have to be elevated to greater than 30 degrees, for example, and these would be in the orders of the chart for the patient. Okay, so they also want 4 to 6 weeks of limited activity due to that surgery, and that person might be on anti-seizure medication. We'll talk more about seizures and medications associated with seizures when we get to the brain injury portion of this course. And finally, we have clinical signs and symptoms for vascular syndromes. These are detailed in O'Sullivan, the tables 15.2 through 15.5. I would highly recommend going through these tables with the lectures from the blood supply to the brain and the brainstem vascular syndromes that we did in neuroscience. Okay, if you don't want to listen to the lectures, that's fine. Just go back and look at the drawings that we did. What I'd like you to do, instead of trying to memorize all the information out of the table, See if you can just use those drawings and pick out the main things that you'd expect with each of these vascular syndromes. And that's what you'll be responsible for. And hopefully everybody remembers the circle of Willis. I have a picture of the circle of Willis and all the major arteries that we talked about previously that supply blood to the brain.